Good evening to all of you. Thank you, Kaho, especially. And I am happy to invite Dr. Jothi Clara, Director of Nursing, IHH Healthcare India, for session Nursing Quality Indicators. Please, ma'am.
Thank you, sir. Much, Kaho officials and Gracie ma'am, for giving me this opportunity to be with you all again. With gratitude of being alive today, all of us, and with all the troubles that we have taken through the corona pandemic, I thank and praise God before I could start this presentation. So to start with the quality indicator. So nursing quality indicator is very special and it is not new to all the participants here. So what is the beginning? It's the beginning when Florence Nightingale measured patient outcome. And what is the reflection for today for us? She used statistical methods to generate report correlating patient outcomes. So are we doing now? Are we using statistical methodology to do that? Over the years, quality measures have improved. So we have heard about quality assurance, continuous quality improvement, quality movement, campaign, accreditation, awards and recognitions, and moving beyond accreditation. Now in India, there is a great leap and bounds, and I should thank the Quality Council of India, NABH, CAHO, JCI, and specifically for bringing in nursing excellence into our country. And this is what has made a great bounce leap in the quality indicator for nursing. Now we learn from advanced country. So this has been very well also told from Sandhya when she was presenting. Of course, American Nursing Association have taken a long step from year after year, and they have brought in a lot of models. And one of the best model is the Donamian model, which helps us to improve specifically on nursing care. This is a very familiar slide for all of us, right? So all the quality indicators here are much familiar to us. And I'm sure these are not only familiar, we are trying our measures to mix and match how we put in all these. I ask a question now to all the participants. Why do you do nursing quality indicator in your hospital? Is it because NABH is mandating it, or JCA is mandating it, or probably your CEO is wanting you to do it, or a quality department is ensuring that you do that? If you say yes, then please change your mind. A mind change is important. We just simply do it to improve nursing. What is nursing quality indicator? This is very specific for us to understand that these are the measures for nursing care quality that use readily available hospital inpatient administrative data. So this helps us to understand where are we in nursing, where are we traveling in nursing care, where we will be in next 3 years, 5 years, and 10 years. And continuous nursing quality improvement is integral because quality indicator cannot stand alone if there is no plot in the continuum. So when we say continuum, continuum is from 0 to infinite. So there is no particular spot where we say we have reached 10%, 20%, 30%. So year after year, month after month, week after week, day after day, we have to keep improving on the quality indicators. Let us reflect for patients what helps make their hospital stay much better experience and how nursing care impacts. It's a very integral question for this particular topic. A smart, competent people, friendly healthcare providers at the bedside are very important. Sorry, there is an error in the type. Who else other than nurses can be fitting into this role? You all would agree because they are the people who are there 24 hours by 7. What helps these providers perform better, especially the nurses? It is the environment that gives us the nourishment for proactive and predictive behaviors. It is a behavioral change. How will my nurse be proactive and predictive? What is the empowerment that I offer to her so that she stands up and she speaks for the patient and advocates for the patient? So where is the destination? Is the very, very important question a nursing chief or the nursing members or the team or the bedside team members who want to improve quality should think of. Now, destination cannot be reached without values, and values cannot be there without the team. So these three are very integral aspects of quality indicator. Now, why nursing quality in the nursing professional toolkit? So nursing has got a toolkit. This is to ensure accountability, transparency, and quality improvement. These three are much important and a critical element of quality indicator. Now, why do we do quality indicator and why do we monitor it? For assessing the provider care, improving the quality of care, for defining strategies to achieve goals and redefining patient care. As the previous speakers very clearly said, we have to keep redefining. Quality indicators helps us to structure and redefine nursing care. Now, how do we identify quality indicator? It's a nursing domain. Can anybody else other than nursing dictate a quality indicator for nursing? No, it is not possible. They could suggest, they should bring to the table, and the nursing team must be the team who decides on which is the indicator we would like to apply. It is a collaborative effect. Nursing cannot stand alone. We need operational team, we need medical team, and we also need the quality support. So all of us together, then we determine, but however, the nursing quality indicator remains within the domain of nursing. Now, how do we do it? We have a scope. So what is the hospital scope? Do we have obstetric patients? Do we have orthopedic patients? Do we have general medical surgical patients? So that is what should be the first thing. And the quality indicator should be relevant to the nursing that is performed in the hospital. Now, what is the depth and the limit of quality indicator? Actually, there is no depth and the limit. Sky is the limit. I've given an example here. Medication error is one simple quality indicator. But see how many categories you can bring into it. For example, in a hospital, we found that there were prescriptions for entry-coated drugs for patients who were on NG2. So the nurses stepped forward and said, I cannot administer this drug because this is not a non-entry coated drug. So you can bring in quality indicator to any extent, and that is why I said there is no depth and the limit. But the beginning hospitals, the beginning team should always think for a generalist and a very significant important quality indicators. Now, the key principles here are appropriateness, relevance. When I say relevance, I give an example here. Initiation of breastfeeding is relevant to obstetric nursing. Simple to complex. Just measure how many patients are having pressure injuries. This is to start with. Then you can go for seeing how do the patients get healed of their pressure injury, and you learn the pattern. So it is important for us also to understand common and routine to uncommon and rare activities around the nursing so that we are able to benefit the larger population of patients coming into a hospital. Nursing indicator starts. This is one example I would like to present to you. Many of the presenters in the past presentation have highlighted about it. See the depth with which we can go into it, like missed breaks. So this missed breaks could be one indicator. Nursing overtime could be another indicator. Nurses cannot do evening shift and the night shift. They would do error. It is important indicator. Planned, required and available nurses for each shift. This is an indicator. High level or ongoing reliance on temporary nurses. Many times, all of you, I see nursing leaders also sitting here, managers sitting here, pull in and pull out. Just pull a number to add to provide care. It is not there that. It is what the nurse can perform and why is she placed in the unit is very, very important. And these are some of the examples I would like to give you to say that quality indicator is just not the quality indicator what we do. It is as a continuum, we have to progress it with depth and breadth. Thanks to NABH, thanks to JCI, and thanks to CAHO for making it visible to all the people. And these are some of the quality indicator relevant areas that we could see very clearly in the standards. And they normally tell us that we have to identify a data, a quality indicator. We have to see how we are selecting and collecting data. How do we analyze and see the variations? And how do we fill the gap? And how do we gain and sustain so that the patient care quality is continuous? Now, coming to quality indicator types, we have structure, process, and outcome. So we can categorize and see. Some of the quality indicators could be structure and outcome related. Some could be process, structure, and outcome related. Some would be just specifically only structure related. So we as leaders must be very clear which of the category the quality indicator falls in. Examples I've given here very clearly, and I'm not going in depth because of the time. Now, when we say structure, process, and outcome, this is a very clear example that I would like to present to you. These are some of the quality indicators which I think most of us do it in our day-to-day activities. Now, when we do this, what is happening? It is helping us to understand where are we in our unit, in our hospital. And then what happens is when we want to develop a nursing sensitive indicator, how do we do it? We can do it by ourselves for the hospital. Whichever hospital you work for, whichever department you work for, you could do it. How do you do it? Identification of potential indicator. So what is a potential indicator for the department? If you are working in an orthopedic unit, then your pressure injury would be the priority one. And fall would be the priority one. So identify the indicator definite to the particular area or the hospital or the scope. Then you search on the literature. When we search on the literature, we get best practices. We know how do we measure it? What are the variables of concern that we have to consider? And what are some of the outcome that is being benefited out of measuring such quality indicator? So then we will be able to have a panel of people, collect few nurses, interested nurses, put 1 or 2 clinicians into it, ask them to validate the indicator, and then prepare a proper plan, conduct a pilot study. Now, QI is basic to balance scorecard. So what is balance scorecard? Balance scorecard measures the performance of a particular group of people. Now, for nursing balance scorecard, if we say in a particular unit, there was no fall for 120 days, there is no pressure injury for 60 days, and so on, then that measures the performance of the nurses. So you put balance scorecard. Initially, you can start with 10 indicator, expand to 15, 20, and so on. If your hospital is going for accreditation, it is mandatory for us to go for all the indicators suggested by the standards. But however, when you start with less number and then you progress forward. But every single indicator, take it very serious so that it helps you to have an inclusive approach, involve people from the ground. Because the quality department is circulating a data sheet, never accept and give the data. Please understand and then get involved. Particular nursing department, for example, a transplant unit, if they are to give the data, the team, those who are originating the data, should be very clear how they are collecting the data. Because when they do that, your right data comes in. So in your validation, you will come to know the validating team will be comfortable saying that the data that is originated has a proper agreement between the validated data and the originator data, which is very significant. So inclusive approach is very important, especially from down up. That is the point that we have to remember here in this presentation. Nursing sensitive indicator, I've given you a few examples. You can have indicators, you can have sub indicators, and you can have define the measures for it. So it can be a wide range. Like you can say that the sub indicators could be many. As I said, for pressure injury, you can have the healing pattern, outside pressure injury healing pattern, inside, and so many other, the patients with albumin level very low, the patient, those who are anemic. So it can go beyond and beyond for sub-indicators. So same way, like you can go for the various category of the indicators, you can have a sub-indicators confidently so that you are seeing that the quality is taken forward widely. This is not enough. We need to move to the next level to impact outcome, because just getting a quality indicator, gathering data and providing the numbers, seeing the numbers and being happy will not be enough. So we have to do a point prevalence study to validate whether whatever data we collect is the same. So agreement and disagreement is very important. So once we know the data collected is correct, and if suppose there is a fall or probably there is a tracheostomy block, so there is, you should see, you can do a cross-sectional audit. Now you mix audit into the quality indicator. So you say, okay, today there is a quality indicator that you had and there is an occurrence that has happened. So you find there is a block. Okay, fine. You see how many tracheostomy patients are there across. Now bring in the audit. Do a cross-sectional audit to say that this is only a single incident, or there is a magnitude to this incident. There is some problem, either competency problem with the nursing team, or probably a product problem with the purchase team. So we have to go to the end to solve it. Now, benchmarking quality nursing indicator. I'm sure Kaho will be taking this forward, because in India, we don't have so far a clear benchmarking for nursing quality indicator. Where do we position our nursing care? Where have we positioned our nursing care so far? We are all working like an isolated ivory towers, but when we compare data, we will come to know where are we, and that will help us propel forward. So what is benchmarking? A continuous process comparing an organization's performance against that of the best in the industry, considering critical consumer needs and determining what should be improved. Now, when we say benchmarking, we have to have regular comparison indicator. So we have to have a data capturing, and it has to be shared transparently. It can be at the unit level. If it is in the hospital, you can have a benchmarking for the hospital. So you have 26 small functional areas in the hospital. Compare between each areas and see what is it. So for this, what is required is ideation, innovation, and exnovation. What is this? Ideation is you have to have a new ideas, how to monitor, how to evaluate, how to bring in a new, fresh mind into monitoring quality indicators. That brings you new innovation. So we'll bring an innovative process, innovative structure, and that will help us to innovative method of training or teaching, or maybe a product innovation comes in, and that makes things better. Then exnovation is very important. This is what is happening in nursing documentation. Everybody feels adding a sheet and then asking nurses to fill will make patient care safer. Never, because we have not exnovated. We have not removed what is not required. We have not removed the duplication. We have not made the document very precise and be contemporary. We are still classical. So exnovation is you have to remove what is not required. I would always say, if you want to do a lumbar puncture and you want to give in a therapy, so you want to introduce few drops into the spinal column. What do? We remove few drops and then we introduce few drops. This is very important in introducing anything in quality in a hospital. See that you exnovate and then you introduce, which is very important aspect for all of us. Leaders have to remember this, because most often leaders do this mistake. So benchmarking can be done at department level, hospital level, national level, and international level. So how do we place nursing? Where is the liver nursing team in global hospital placing themselves in the hospital level? And where are they placing themselves with the state of Tamil Nadu, with the state of, with India, and nationally and internationally? So this is how we have to propel forward to see how we are improving on nursing. So this is a step, very simple. I'll be sharing the slides with you. So when you take through these steps, you will understand how to benchmark, and it is not a tough thing. Each step has got a relevance. So the step 1 talks about service or activity to be improved. The second step speaks about the reference point. And then third one talks about collection and organizing of data. Then the fourth one is like you will see, identify the competitive gap by comparing against external data. How come somebody else is able to perform better? How come this particular hospital fall is very less? Injuries are very less. What went right is very important. Many times we go for what went wrong, but we have to see what went right. Sometimes when we learn from what went right, it is very positive. In our hospital, we did best catches. So when we see best catches, nurses are very interested to catch deviations, catch mistakes. So there comes a safety, there comes a protection, and there comes a learning. It is very significant that best catches and what went right helps us to propel forward. And set future performance target. These are objectives, and communicate benchmarking results, develop actions, and then what do? You do a project management, and that's how the quality indicator becomes a QIP, and then you put a benchmark, and then you start monitoring against that, and you keep improving. And this is a very nice diagrammatic representation of NQI to performance of the organization. So our CEOs will be very happy if our patient, if we say the patient's length of stay is 7 days as per the package. I challenge as a nurse, I would send the patient home by 5th day. It is because of the improved nursing care. CEOs will be very happy because you're reducing 2 days of stay for patient. Patients are very happy because they are going to pay less 2 days in their package. And if they have to, from the out of pocket, if they have to pay, it is a reduced cost for the patient, and you're making the bed available for another patient. So this is how the quality indicator should reflect performance. So leaders in nursing, when you sit in the boardroom, please communicate to your leaders saying that your nursing indicator is helping the performance business of the hospital. So this is how you see the quality indicator supporting the business and growth of the organization. Now, what is the role of a nurse? I would just simply say the red one that is there, the statement, sharpen nurses EQ and CQ, emotional quotient and curiosity quotient, and empower them to express without fear while at bedside and in boardroom. Very important. The chief nursing officer, all the nurses, those who are sitting in the committee, what do? When you present the quality indicator, contribute. Please give in points so that you will be able to be in the top and not in the bottom. And nobody gives us that. We have to claim it. And that is possible when we have the nurses at the bedside should have curiosity. Why did this diabetic patient get better with the same care that I've provided? Why not the other patient? Ask your doctor. So this is very important. And this asking is also related to quality indicator. The last slide is like, how do we involve the chief nursing officer? She sets the tone, and she is the pivotal person to take quality nursing indicator forward. She must have a vision. She must have a long-sightedness. She should be doing a scan, off-site scanning. While sitting in her office, she should know currently what is happening at the bedside. How many of the patients are not given blood transfusion within the turnaround time? There is a delay. So she should be having that off-site. So the indicator, what new indicator? Sit in the mortality morbidity review. Identify what is a quality indicator you have to pick so that another patient, preventable death doesn't happen in the hospital. Preventable mortality doesn't happen in the hospital. These are all beyond what you do now. And nursing managers, they have to be involved. They have to be engaged. And they help us in the process because they are the implementers. Don't think it is not enough for them. Just give the sheet and ask them to do it. No, involve them in the plan, involve them. I saw in the previous presenters, plan is the largest time consuming thing. If you take more time to plan, your implementation and evaluation will be lesser time and lesser effort, and outcome will be better. The direct patient care nurses, they have to be empowered. They are the key because most of them are the data originators. If they rightly originate data, here comes their ethical practice. That is what we have to drill in. The DNA that is set in for quality. Very important. Then data originators, data validators to be defined in the hospital. They cannot be same. Not an additional task, but a frame of mind is very important. So let us see that how we set the mind so that we are able to help nurses to identify, come forward and identify. This is what we talk in research as deductive and inductive reasoning. Inductive reasoning is from the bedside, you get the reasoning. So many things are happening. So let us go and explore. When we take a blood sample, so you do certain method. So something comes from the bedside, and from bedside nurse, you will identify, oh, this is nice. I think we have to put this as a quality indicator and we have to keep monitoring. So encourage your nurses to do an inductive reasoning and contribute to the boardroom and the business. This is what is important in the quality indicator. Now, what are the factors related to this? It's very simple and clear for you. We need a competent nurse, independent and autonomous practice. Management support is very important. Patient-centered culture, patient first is very important. And collaborative working environment. There is no hierarchy. Medical profession is not bigger than the nursing, and nursing is not bigger than a housekeeping. Everybody has a part to play, and we are all working in a circle, and there is no hierarchy when it comes to different domains. And availability of continuous education is important, and the nurses directly affect the quality in the hospital, and we have to make an investment for them. And what are some of the difficulties? Many times we say lack of time, inadequate numbers of professionals, lack of knowledge on subject, lack of understanding of how to use these instruments. So these are some of the things we always give as an excuse, but these are not excuses. Once we put a mindset, we will overcome all these excuses very easily. And then the relationship between quality and empowerment gives us leadership support team, and communication and information sharing, positive reinforcement, confidence, and just culture. And these are some of the barriers which I'm not going to tell, because I think we are all struggling to overcome these barriers, and we are all very supportive. Otherwise, you all wouldn't have paid and come for this particular program here and wanted to learn more. With this, these are some of the references I've taken. It was a beautiful learning experience for me. Although I am an assessor, although I'm doing quality indicator, it was very refreshing because I had an opportunity to sit back, reflect, and then to give a presentation of this kind. So may I end with a quote: nurse, you are a patient advocate and express without fear while at bedside and in boardroom. Quality means doing it right when no one is looking. Never ask for reward. Reward will automatically come. Just keep doing what is right and what is good. Thank you all.